Ladies and gentlemen, please have your seats. Ladies and gentlemen, kindly gather back as we resume our next and final session of the day. What's new on trauma? This section will explore the latest updates, research breakthroughs, and clinical innovation shaping the future of trauma care. I am pleased to introduce our moderator, Dr. Sohaib Najam, who is working as a fellow of trauma surgery at AKU. Please welcome Dr. Sohaib with huge round of applause.
All right. Assalamu alaikum and good afternoon, everyone. I formally welcome you all in today's session over trauma. So, trauma management is a complex and multifaceted discipline that requires a comprehensive approach from pre-hospital care to definitive treatment. The impact of trauma on individuals, their families, and the communities is profound, and it's essential that we continue to advance our knowledge and skills to provide optimal care. Over the next 2 hours, we will be exploring the multidisciplinary approach to trauma patients. This discussion will cover a range of topics, including trauma resuscitation, trauma registry, interventional radiology, and use of AI. Now, let me introduce to you the chair and co-chair of this session. Our chair of the session is Professor of Surgery at AKUH, and his area of expertise is trauma management. He is also the Program Director of Trauma Fellowship Program at AKUH. Please welcome on stage Dr. Hasnain Zafar. Next, our co-chair is the Professor of Surgery and in charge of Surgical Unit 2 at Civil Hospital, Karachi. In addition to his responsibilities as a surgeon, he is involved in health professional education and is Director of Distance Learning and Online Teaching of Dow University of Health Sciences. Please welcome on stage Dr. Zubair. All right, so we will now begin with our presentations. I would request all the presenters to keep their presentations within time. Our first presenter is Dr. Madeeha Ali, Assistant Professor of Surgery at Dow Medical College, and her topic of discussion is Mastering Trauma Team Dynamics and Effective Trauma Leadership. Please welcome on stage Dr. Madeeha Ali.
Assalamualaikum. Good afternoon, everyone. I'm sorry I have a bad throat. I hope you'll bear with this. But I'll be crisp and short with my presentation. So can we start the presentation, please? Okay. So today I'll be talking about high-performing trauma teams or high-functional trauma teams, which is basically how we master team dynamics and effective leadership. So in today's presentation, which starts with a short video, if you can play the video, please. So this was a very short and exact description of a high-functioning team. So this was basically a Formula One pit stop in which the crew of 20 people, almost 20 people, have different duties and roles, but they work in such a synchronization that you cannot differentiate that who was doing what, and the job assigned was done in a blink of an eye. So why do we need high-functioning teams? Because trauma is basically the most leading cause of deaths in young population, especially under the age of 45 years. And then it has significant financial outcomes. It leads to disability, it leads to productivity losses. So that's why we are eager to learn trauma management along with high functionality so that our trauma teams are better equipped and more effective in dealing with trauma. So, it's not working. Sorry for the disruption. Okay, so as we just spoke that why this matters because we need effective trauma teams to deliver effective trauma care. And this trauma team should work in excellent teamwork collaborations, should be equipped with excellent communication skills and leadership because all of these will help to improve the outcomes of trauma because trauma outcomes just do not solely depend on your medical expertise. It also depends on how you lead a trauma team. So the next slide, please. Next slide, please. What defines a high-performing trauma team? So as we just saw, that a high-performing or high-functional team works in synchronization. It looks like if they are dancing or very synchronized in their movements. So there are two types of traits that are present in trauma teams, which are high-functional, highly effective. One is the core trait that should be present in each and every member of the trauma team. And then there are features that are present in the teams which, as in the whole team should follow. So the core traits that should be present in each and every one of the member of the trauma team is role clarity and responsibility or accountability, liability. So if you are already aware of what role you are supposed to do when a trauma comes, you automatically do it with your muscle memory. And if you are accountable and held responsible for that, you're more efficient in delivering that responsibility. Then the second most important thing is communication skill. We all know that trauma is not just communication with the patient, but interdisciplinary. A lot of other disciplines are involved. Patients, families are involved in this because they are going through a difficult time. They need communication as well as empathy. So that's a very important tool that you should have. Then situational awareness, as in what is happening currently with the patient in the emergency room, outside the emergency room, in the pre-arrival time. So situational awareness should be the most important thing for every person in the team. Then obviously technical proficiency. No one can excel without knowing what he or she is supposed to know technically, medically. Then emotional resilience. Obviously managing trauma is not an easy thing. You have to be very resilient with your emotions because traumas can be very disturbing emotionally. So you need to develop that resilience with time, with different tools, with workshops and courses. And then shared mental model. A shared mental model is a very very interesting topic, I would say, or interesting ideology or theory. That shared mental model means every person in the team has the same instincts. So they all work in the, in a given scenario, everyone will react similarly. So this is what is important. So if everyone will respond to the same thing, similarly, this will make your trauma team work more efficiently. So these are the very important core traits of a high-functioning trauma team. Then coming to the team-level traits. So these are traits of the teams collectively. Effective team leadership, obviously, the team leader is the one who will sail the ship, and it will depend on him or her how smooth the sail is. Interdisciplinary teamwork and collaborations, you have to deal with anesthesia, nursing, radiology, and many more teams to give the best care to your patient. And then, as we said, situational awareness, but as a collective team situational awareness. So everyone in the team knows the same thing, the same amount of knowledge, the same scenario, the same information. And then communication culture, it should be safe. Everyone should be allowed to speak. Same as the psychological safety. No one should be felt harassed or had a fear of talking, especially while dealing a serious situation. And then, so the last but the most important thing is training and continuous improvement. So if a team works day in, day out, it develops certain traits. But it's important to train them so that they have the best of those traits. So continuous training is the most important thing. They have to repeatedly update their skills, their knowledge, and this is the most important thing as a team. So why do we want to master team dynamics? Because we all know that there's a golden hour in trauma. You have to act immediately to avoid the patient leading into the death of the triad of death, and to act quickly so that the patient doesn't go into an irreversible state. Also, the impact of poor dynamics. So if the team dynamics are poor, obviously there will be delays, there will be errors, there will be things which will be missed, there will be things that will be repeated, and that will create frustration. And when the team is frustrated, obviously they will not give their 100%. So that is why we need to train ourselves in a way that delays and errors and frustration is minimum, and the care given is 100%. It also obviously impacts the outcomes of the patient. So if you give 100%, you will have 100% outcomes. So human factors. Humans are a complex organism, we all know. So stress, fatigue, communication, these are all things that you need to manage side by side along with your clinical education and your clinical knowledge. So there are different tools available, there are different courses available, there are different trainings available to use and modify your communication skills, your fatigue and stress management. There are aids that help with cognitive functions, so use those. And then provide a supportive team environment so that everyone in the team works in a calm, composed environment without additional stresses, and deliver their best. So to standardize protocols and to minimize your cognitive overburden, and to give standard care to each and everyone, and to have a shared mental model, we have to follow standardized protocols. There are a lot of protocols being made internationally, locally, by their hospitals. So try to make one for yourself, for your team, and then adhere to it. So there are different, as we all know, we use ATLS the most. There are European trauma courses, and then there's massive transmission protocol, and then every facility has their own certain protocols for trauma management. So try to adhere to those and follow those. Okay, so team communication is the most important thing. We have been through this in other specialities as well, that every communication should be clear and closed loop, which means if you send a message, you should receive a reply to whatever you have given the message about. So another important thing is, this is communication in the team, but then there's communication between the teams. As in, if one team is ending their shift and the new team is coming, so you have to give a proper over to the other patient, proper handover to the other patient, so that nothing is missed, nothing is duplicated, and the patient care is optimized. And these are use of S-bars, team steps. These are different tools which are used for handing over patients from one team to the other team. Okay, so the leadership is, again, obviously another very important thing. So the leader sets the tone of the team. If the leader is chaotic, the team will be in chaos. If the leader is calm and composed, the team will work in a calm and composed environment. So he brings order to the chaos. and then he assigns roles, he maintains the calms, and is very adaptable to change, because there will be situations that will change, and that will require the leadership to change and evolve accordingly. So decision making under pressure, it's a very and then what are the communication facilities available to them. So these are all the important things that they discuss between themselves when they are doing a hurdle. And if you can see, there are a number of people present in the hurdle. So the trauma attending, the trauma fellow, the trauma residents, the nursing staff, the emergency staff, everyone should be present there when the hurdle is going on. So regulating stress in high stakes team is very important, because as we just spoke, that no one can work in a stressful environment. It's very difficult to work in a stressful environment. So to make ourselves powerful in a crisis, we need to model calmness. We need to promote clarity between ourselves and to allow decompression post-event, which is a very important thing. If we do routine decompressions post-event, it will help improve our policies and our management. So conflicts in any team is inevitable. So, but in teams which are functioning during a stressful period, in a very fast pace, these are even more common. So what we do is we address them early. We try to focus on the process, and we try to standardize the process, and do not do a blame game on team members. That will help the team members to grow more and learn from their previous mistakes. And there's importance of using debriefs very occasionally, after every shift, after every call, after every trauma bulk. So these are very important aspects of learning. So the importance of debriefing, as we just spoke, what are the important things that we discussed during the debrief? We discussed what went well and what didn't, and then we try to see why it didn't work well, and then we try to make changes so that these things do not repeat in the future, and we learn from our mistakes. So the debriefs should be open, safe, and structured, so that everyone is encouraged to speak and share their ideas. Okay, so no teams are born high functional. They are built and then they are sustained. So building a team, as we all speak, as I just spoke to you, how is a team built, but how are they sustained? They are sustained by continuous training and simulation, and that too in a low pressure area when they are not dealing with actual traumas, which means they are training on high fidelity scenarios. They are team drills, they are following the crisis management principles, they are doing their skill stations with a video feedback, and then their regular ongoing training through different courses. And then there is interdisciplinary collaboration. So they collaborate with each other, like the emergency team, the surgery team, the anesthesia team, the nursing team, they collaborate with each other, and then with the allied teams like radiology, lab, pharmacy, respiratory therapist, all of those. So joint training and clear protocols makes your trauma care effective. So there will be challenges in implementation of these things. There will always be challenges when new things are evolved or new things are implemented. And these changes should not stop you, but they should push you to do more, so that you can overcome these hurdles and provide better trauma care. And then the last thing is, if we do not measure our performance, we cannot improve it. Because if you don't measure anything, you cannot improve it. So measuring outcomes and measuring our time to critical interventions, protocol adherence, patient outcomes, teamwork and collaborations, and communicative skills should be measured. And then once you have measured those, then you are in a position to improve. So that is why measurement of all of these parameters are important to improve yourself in the future. So the take-homes are very clear, that leadership is very important. The leader will direct you either in a very chaotic mode or a very calm mode. Obviously, practice makes you perfect. Do team drills when you are not working on a trauma patient. Try to enroll yourself in different trauma evaluation courses, trauma management courses, and even if those guidelines that you have already, try to adhere to them, and then continuously follow those and train on those. If you have missed something in the past, try to overcome that and improve yourself. And then know the system, not just the steps, so that if you know the system but not the steps, you will do something in a haphazard manner. But if you know the system and the steps, everything, everything will be synchronous, just as we saw in the Formula One pit stop. So this is the end of my talk, and we'll have question answers at the end. Thank you.
Thank you, Dr. Madeeha. That was a very comprehensive talk on team work. Our next presentation is by Dr. Faisal Shamim, Associate Professor and Consultant in Department of Anesthesiology at Aga Khan University Hospital. His areas of clinical and academic interest are airway management, head and neck anesthesia, ultrasound-guided nerve blocks, and critical care. His topic of discussion is controversies in trauma resuscitation. Please welcome Dr. Faisal Shamim.
Assalamu alaikum. I'm extremely thankful to the organizing committee of Surgicon for giving me this opportunity to talk on this prestigious forum. Controversy topic is always very interesting because it will remain as a controversy. So nothing to declare. We know all that intravenous fluid resuscitation has maintained a prominent position in any algorithm of the trauma patient. And the goals and principles of fluid resuscitation in these patients in this acute resuscitative phase, which is pre-hospital transport and in the emergency department, is to prevent deterioration by further controlling the bleeding, restore the physiological hemostasis by restoring the lost blood volume, and regaining the tissue perfusion and organ function by preventing and to prevent the death. So the resuscitation of trauma patient has evolved significantly in recent years, and certain dogmatic practices have been found to be very deleterious and largely abandoned. So what the best choice of fluid, the volume strategy of fluid resuscitation in varied injuries, the monitoring during resuscitation, and the appropriate endpoints for resuscitation. These are all debatable. So the aim of this presentation is to provide an overview of the contemporary literature regarding the fluid resuscitation in trauma. So initial trauma resuscitation fluid volume. We all know that historically the ATLS recommended straight 2-liter crystalloid every patient who's coming with shock in the trauma patient. But the more recent editions of the ATLS have reduced this to 1 to 2 liters, and even they suggest that initiate resuscitation with blood products early, which is a little bit difficult in our practices and in our circumstances where the blood availability is a little bit problem. ATLs also encourage a more balanced approach nowadays. So limiting crystalloids. We all know that the traditional concept of early and aggressive fluid resuscitation in severe trauma is associated with a lethal triad of the trauma, which is dilutional coagulopathy, acidosis, and hypothermia. And there is a growing evidence, currently there is growing evidence that this aggressive fluid resuscitation with crystalloids, they tend to increase the arterial and venous pressure, they tend to promote the intra-abdominal hypertension and many more complications and promote dilutional coagulopathy. So while over-resuscitation is associated with poor outcomes, the question is whether less aggressive strategies result in improved outcomes. So Scriber et al., they looked at and they randomized 192 hypotensive patients to a controlled resuscitation and standard resuscitation. Controlled resuscitation means giving 250 ml of fluid and just maintain the systolic blood pressure of 70. And the standard resuscitation is to give fluids and maintain systolic blood pressure of 100 millimeters of mercury. And what they found is that the 24 hours mortality in hospital mortality were similar in those group, and renal injury a little bit more in the restrictive type of strategy, but that's not statistically significant. What it tells you is that the controlled resuscitation was also achievable and safe, so don't need to be very aggressive with crystalloids. Permissive hypotension. So this has been explored in various studies, and we know that there will be times when we take any patient with the trauma, with the shock, and everybody is trying to maintain the blood pressure and give everything you have the availability of any fluid availability. But we need to choose our short-term and medium-term goal, and this concept is the foundation of damage control resuscitation, which actually comprises of damage control surgery, permissive hypotension, and resuscitation with the blood products. So the permissive hypotension, what is the strategy is the limit fluids and maintain lower blood pressure until the bleeding is controlled. So it prevents dilutional coagulopathy. The benefits and outcomes of this strategy is decreased transfusion needs, decreased postoperative coagulopathy, decreased early mortality, and better clinical outcomes. Where it is still used is the penetrating trauma with active hemorrhage and no traumatic brain injury, preoperative or pre-hemostasis phase of resuscitation, and where the situation where rapid control or intervention is available. Where it is avoided or used cautiously is the blunt trauma with traumatic brain injury and the elderly patients with cardiovascular disease. So a review was published in 2021, which compared the permissive hypotension versus conventional resuscitation. Permissive hypotension is also known as hypotensive resuscitation. So the hypotensive resuscitation appears safe and is associated with decreased mortality rate when compared to normotensive resuscitation. So there is less blood loss, there is less hemodilution, there is less ischemia, and there is less hypoxia. So ideal resuscitation fluid, to me, there is no ideal resuscitation fluid. We know that parenteral fluids are divided into crystalloids and colloids. The crystalloids are being divided into hypotonic, isotonic, and hypertonic, and the colloids have been divided into synthetic and natural. The most common fluid used in the trauma resuscitation early is the normal saline or the Ringer's lactate. One of the group of intensivists from Belgium, they always say normal saline is abnormal saline because it contains large chloride. It causes large chloride overload, which causes the hyperchloremic metabolic acidosis, and that causes impaired renal perfusion as well. The balanced salt solutions like the Ringer's lactate, Ringer's acetate, which is also known as Hartmann's solution, Plasmalite, or Styrofoam, they have a minimal effect on pH and overall no effect on renal perfusion. Sometimes sometimes they become hypotonic and they have a higher cost. We know that hypertonic saline have been used in traumatic brain injury. This has been explored, hypertonic saline, as a resuscitation fluid in trauma, and 7.2% have been explored. Rationale for use that we may require a smaller volume. There is potential to reduce cerebral edema. They may improve hemodynamics and microcirculation rapidly. But a multi-center randomized controlled trial, is being hampered early because of the higher mortality. And the current status of hypertonic saline in trauma is it has no part or not part of the standard algorithms right now. So this debate will continue until this world ends. Crystalloid versus colloid debate. And the crystalloid over colloid debate revolves around balancing the efficacy, safety, cost, and long-term outcomes. Most of the trials, like crystal trial, safe trial, which is the albumin versus saline, these all trials doesn't show any 28-day mortality benefit of the early use of synthetic colloids in the management of trauma resuscitation. So European guidelines, which is in 2023, they say favor restricted use of crystalloid, blood products prioritized, and colloids not recommended. So evidence-based recommendation is, again, most guidelines recommend start with crystalloid. Ringer's lactate or the other balanced solutions are preferred. Colloids may be considered in the later part. Large RCTs show no mortality benefit. And the individualized approach is fluid strategy should be tailored to patient-specific factors. Blood product components. Now, the timing of component transfusion is important. This is a famous prospective observational multi-center major trauma transfusion study, which shows an early plasma and platelet transfusions are associated with a substantial reduction in mortality. Delayed transfusion post 24 hours do not influence mortality, highlighting the importance of timing in trauma resuscitation. Effectiveness of transfusion, all people present here will be practicing this 1:1:1 practice of 1 RBC, 1 pack cell, 1 FFP, 1 platelet. But one trial, which is randomized optimal proper trial, they also looked at the transfusing 2 RBCs and 1 plasma and 1 platelet, but they don't find any statistically significant difference. There are lower deaths from exsanguination in the 1:1:1 group, no significant difference in overall mortality, and improved hemostasis. So there is no need to give 2 pack cells. We continue this practice of 1 pack cell, 1 FFP, and 1 platelet. Again, use of pre-hospital plasma means FFP. The trials are a little bit, some in favor, some in against. One trial says that there is a lower 30-day mortality, but most of the trials doesn't recommend use of FFPs in the very early part of the resuscitation or the pre-hospital transport during the pre-hospital transport. So whole blood, again, it's coming back. Whole blood versus component blood products in trauma resuscitation. Some studies have shown that whole blood may improve survival rates. This is a bulletin of American College of Surgeons in 2023, and the most downloaded article from the Journal of the American College of Surgeons in 2022 was impact of incorporating whole blood into hemorrhagic shock resuscitation. And the study showed that compared to using blood component therapy in patients experiencing hemorrhagic shock, whole blood transfusion improved 30-day survival by 60% and reduced the need for 24-hour blood by 7%. So use of cryoprecipitate in trauma resuscitation. Cryoprecipitate is a plasma which contains fibrinogen, factor 8, von Willebrand factor, factor 13, and fibronectin. There are a lot of studies about evidence supporting the use of cryoprecipitate in trauma resuscitation. The cryostat in 2016 showed early administration of cryoprecipitate within 90 minutes is logistically possible and safe. The European guidelines on trauma bleeding in 2023 suggest fibrinogen supplementation when level falls below 1.5 to 2 gram per liter. We also check whenever there is a dilutional coagulopathy or there is an ongoing coagulopathy. If you check the fibrinogen levels, if they are below 150, then there is a recommendation of giving cryoprecipitate. Tranexamic acid, transamine, it has a proven role in trauma resuscitation, particularly for bleeding trauma patients. Tranexamic acid administered 3 hours after injury was shown, within 3 hours after injury, was shown to reduce 28-day mortality among patients with suspected bleeding, which is CRASH 2 trial, and among patients with mild to moderate traumatic brain injury, CRASH 3 trial. So viscoelastic assay guided resuscitation in trauma, the point of care testing, which is called the TEG, thromboelastography, and ROTEM is the rotational thromboelastometry. These are the point of care tests that assess clot formation, strength, and breakdown in real time. Benefits of this point of care testing is targeted resuscitation. It avoids overuse of FFP, platelets, and cryoprecipitate, but it has a faster decision making in critical moments, but it requires training and expertise and may not be available in low middle income countries. So evidence of this TAG assisted resuscitation is ITACTIC trial, which is 2020, which is video viscoelastic guided resuscitation, did not reduce 28-day mortality. However, it also reduced use of unnecessary blood products. So widely adopted in European and some US level 1 trauma centers. So massive transfusion protocols, there are some scoring systems. When you will activate the massive transfusion, there are 2 types of scoring system, which is assessment of blood consumption score and revised assessment of bleeding and transfusion score. These scores are being used when massive transfusion protocol should be activated. And compared with the ABC score, rapid as a revised assessment of bleeding and transfusion score has a reported higher sensitivity and specificity. So while there has been an extensive literature when to initiate massive transfusion protocol, there is little written about when to cease it, kab humne band karna hai. So important area of investigation is MTB utilizations is resource intensive and blood is generally of limited supply. Achieving hemostasis is one point, fatality is another, and attempts to define fatality have been unsuccessful. So in conclusion, aggressive resuscitation with crystalloid is largely abandoned. Basic principles, protocolized resuscitation strategy, early transfusion with whole blood or component therapy of 1:1:1, limit crystalloid use, use of tranexamic acid within 3 hours of injury. And then there are some recent innovations like people are using dried and liquid plasma, and future developments is regarding the artificial blood transfusion. Thanks so much.
Thank you, Dr. Faisal. So moving on next, our next presenter is Dr. Nasir Khoso, consultant anesthesiologist and critical care physician at South City Hospital. He is the Director of Critical Care and Emergency Services and leads the trauma team and rapid response team in South City Hospital. Please welcome Dr. Nasir Khoso.
Assalamu alaikum. So my talk is about what surgeon needs to know about trauma anesthesia. When I did a lot of research that what anesthesiologist should know about trauma anesthesia and what surgeon should know about the trauma anesthesia, so I didn't find a much difference. But this is not your job, this is not my job, this is our job. When we have a trauma patient, so there's no boundaries that this is your job, you have to do this job and I have to do that job. Ye to uska kaam tha. We don't need to say that it's our job. So what are the objectives of my today talk? That the overview of key anesthetic consideration in the management of trauma patients that surgeon should know that. And to improve the interdisciplinary understanding between the surgery and anesthesia team for the optimal trauma resuscitation and operative planning. To highlight the practical insight on the airway management, volume resuscitation, and anesthetics challenges in severely injured patients. So the scope of the problem. The trauma is the leading global cause of the death for the people aged 4 to 44 years. And the anesthesia-related complications contribute to secondary injuries. Poor communication between surgery and anesthesia leads to delay in avoidable morbidity. So in some literature, it's said that the trauma is a third leading cause globally, and it's a 1 in every 5 seconds a person died due to trauma. And which one is the first killer cause? That is the sepsis. So every 1 is to 2.5 seconds a patient died due to sepsis. So sepsis and trauma are the more leading cause of the death. So the anesthesiologist and surgeon both are very critical role in the sepsis and trauma as well. So the trauma, where anesthesia intervenes. Anesthesia intervenes is taught at the pre-hospital era. When a patient in the trauma, first, most of the time surgeon get a call that there is a mass casualty in somewhere else at the road and patient are coming to the hospital. So a first step is to intervene, to contact the anesthesia. Surgeon should contact the anesthesia that we have that type of trauma and coming to our hospital. And second, there's a rapid sequence inductions and the oxygenations and the use of ketamine, intermediate use. In the ED, the airway stabilization, shock control, and triage. In the OR, that is a controlled hypotension, hemostatic resuscitation, damage control anesthesia, and damage control surgery as well. In the ICU, that is a ventilation, sedation, and post-resuscitation care. So there should be a closed loop communications. There's a coordinate across the surgery, anesthesia, emergency department, include anesthesiologists in the key perioperative decisions, and ensure a clear transition of the care. So the airway management, that is the first battle. So the challenging airway are frequently encountered in the case of maxillofacial, cervical spine, and thoracic injuries. Video laryngoscopy is method of choice with first pass success rate is almost 85%. And they ensure the surgical airway preparedness, perform cricothyroidectomy within the 60 seconds, and even unsuccessful intubations. Rapid circular ejection is a norm, pre-apneic oxygenation and pre-oxygen are the essentials. So airway collaboration, what surgeons should know, that they stabilize the cervical spine during the intubation. So surgeons should share the anesthesiologist that they stabilize the cervical spine. And avoid blind NG tube placement and suspected basal skull fractures. And recognize the airway bleeding and help to optimize in positioning. So now the intraoperative. The intraoperative, the most important is resuscitate strictly. Dr. Faisal Shamim already told detail about that. So anesthesia's critical role is to prevent the permissive hypotension. That the MAP should be 65 or systolic blood pressure should between the 80 to 90, except in the case of TBI. That because in traumatic brain injury, we have to maintain cerebral blood pressure more than of 60 mmHg. So the hemostatic resuscitation, that is a balanced and targeted. Dr. Faisal Shamim already told about that. That the 1:1 transfusion is have more benefit than 1:1:2. And the, again, tranexamic acid infusion within 3 hours of the injuries, the 1 gram bolus and 1 gram infusion over the 8 hours. The surgeon should also know the type of the shock. It's very important for a surgeon that in trauma patient, which type of the shock we have in our patient. We categorize the 3 major causes. One is hypovolumic. In the hypovolumic shock, if surgeon know about that our patient have a hypovolumic shock, then the aim of the surgery is different. Then we have to control bleeding and avoid vasodilating agent and avoid and minimize the operating time. And if there is an obstetric shock, the surgeon should help the urgent surgical relief, like if there's a tamponade in pneumothorax. And if there is a neurogenic, then manage bradycardia and hypotension. So now the induction of anesthesia in trauma patients, there are certain things that are very important. Surgeons should know some basic induction agent that can be used in the trauma patient. Number 1 is a ketamine, because ketamine have a very good sympathetic preservation. And second good agent is etomidate, because it have a stable and neutral blood pressure. And the avoid propofol, because usually we use a propofol as the induction agent. So please remember that in the trauma patient, so we have to avoid the propofol because there's a risk of hypotensive risk as well. And then succinylcholine is preferable neuromuscular blocker unless it's contraindicated, like avoid in the burn, avoid in crush injuries. In case of hyperkalemia, we have to avoid succinylcholine. Now the anesthesia management during the surgery. The goal of the anesthesia management during surgery is preserve perfusion and oxygenation, avoid acidosis, coagulopathy, and hypothermia, Use warming device in warm fluids and avoid hyperventilation unless there's a raised ICP. So the intraoperative monitoring a response. So the monitor, along with the routine monitoring, we have to monitor lactate as well, bass access, urine output, and sub-invasive blood pressure as well. And the use of rotem and tag, if available, is an accident for the coagulopathy. Now, there are certain things that intraoperative indication for damage control surgery secondary to hemorrhage. This is again very much important. If there is any venous bleeding not suitable for surgical control, so convert your surgery to damage control surgery. So if persists bleeding despite of several transfusion of the blood products more than 10 unit of the packed RBCs, or massive transfusion, that is a 6 unit of the RBCs during first 4 hours. Increase in continuous need of fluids due to inactive non-arterial bleeding. Hemodynamic instability require persistent vasopressor support are the result in development of the ventricular arrhythmias. Or the coagulopathy result in a combination of hypothermia, there's a temperature less than 35, or acidosis is at pH is less than 7.33, and the loss of coagulation factors. In the unanticipated prolonged surgery in trauma patient, if more than 20 minutes, then convert your surgeries to damage control surgeries. So the post-operative consideration that is called ICU bridge, the prevent brain injuries, ARDS, and renal failure, these are the most important things, and optimize ventilation, sedation, and nutrition, discuss ventilation, vasopressor support, and sedation plan with the ICU team, and confirm blood and fluid balance, and communicate injuries in operative course during handoffs. Now, the understanding of surgical stress response is another very important thing. Anesthetics and analgesic used during perioperative period can modulate the innate and adaptive immune system, impact patient recovery and long-term outcomes. Now, the regional anesthesia in the trauma is also very much important, that reduce the use of opioid, use peripheral nerve blocks where it is safe, avoid in case of compartment syndrome, and it also help in plan discharge around the pain management, rebound and catheter, all these, it will help also in all these things as well. Now the practical point for the surgeons, that is the share finding early as soon as possible, like fast scan, any bleeding source, to share that finding as well. And the respect anesthesiologist timing in the safety. Recognize the decompression sign of the patient during intra-op, and plan ICU handoff with anesthesia. So these things are innovation of improve the outcomes. One is a pre-hospital blood transfusion. This is again very much important. Nowadays, a very innovative ideas that improve the outcome, that POCUS, do the POCUS ultrasound and the ED in the intra-op, and ROTEM for coagulopathy management. So the core concept every surgeon should understand, that is the airway management in the trauma patient is very much important. Hemodynamic stability, we should know how do we do the hemodynamic stability and what are the resuscitation endpoint, when we have to activate a massive transfusion protocol. And the multidisciplinary collaboration is very much important in understand the surgical stress response. Now the summarize point that trauma anesthesia is resuscitation plus physiology and teamwork. Understanding anesthesia challenges improve outcome, and surgeon plus anesthesiology is a stronger outcome. Thank you.
Thank you, Dr. Nasir. Our next presenter is Dr. Azer Shaikh, who is a trained senior emergency medicine consultant and head of emergency department at Shaheed Mohtarama Benazir Bhutto Institute of Trauma. He has developed a particular interest in resuscitation and trauma care, and his topic of discussion is establishment of trauma registry in a public sector hospital.
Assalamu alaikum. Thank you very much. I'm very honored and thankful to the organizing committee to invite an EM physician to the Surgicon. Thank you. Before I start, I must ask that everyone is still awake because we all had a lunch. If you feel tired, kindly stand up, stretch your arms if you have to, please. Because it sounds a little bit boring, but what the topic is unique, and we all need to understand what exactly it means. So thanks for the introduction. I worked for NHS for 15 years. I'm UK trained in emergency medicine. I'm member and fellow of College of Emergency Medicine. For last 3 years, I've been working as a head of emergency department for SMBBIT. And I've been a lead for establishing the trauma registry for last 3 years for the trauma center. And what I have learned, I will try to share my knowledge with you today. So in next 10 minutes, it's a very short time, but I will try to squeeze everything what we need to understand about the trauma registry. So as I mentioned, I'm currently working at Shahid Mohattarma Benazir, but to most of the people who are from locally Karachi, they know SMBBIT. It's a level 1 facility, 500 beds. It's completely free. Emergency department manages more than 500 patients of different ages, all ages, I would say, in a day. All the major surgical specialties under one roof. So that's the brief intro to my hospital. So why we need a trauma registry? We listen to Madeeha. She talked about the high performance team in the major trauma. Then we listen to the anesthetist from Aga Khan, and then followed by our South City, Dr. Khoso, that what surgeons needs to know. Now this is trauma registry, that once you have started seeing the patient in emergency department, and then you manage the patient, probably patient is gone to the OT, and then subsequently to the ward, and maybe discharged. Now, whole this journey need to be looked at to improve the care, and this is what it is about. So globally, we need to understand, before we understand the trauma registry, that what exactly the trauma burden is. The global burden in 1 minute, 2 deaths, that's the global number. It's a large number, okay? Which means that 1.19 million die from road traffic crashes annually. And 93% of fatalities in low and middle income countries like us, and 1 in 10 deaths in Asia due to injury. It's a significant number, so the problem do exist. We need to identify. Then we will know what's the importance of the trauma registry. Now, what's happening in Pakistan about the trauma? We all know road traffic crashes, collapsed buildings, flooding. Population of about 229 million. Median age is only 23. Road traffic mortality is 15 in 100,000. Second leading cause of disability, 11th for premature death. Again, a large number. So the trauma registry is an information system that tracks severely injured patients, their interventions, and the outcomes. And it's a core tool for trauma system improvement. So this is what you need to improve your systems in the hospital, in the community, and the government level. So data collection, care provider, and the outcomes. That's what we look into this. To understand more broadly, we need to look at this pictogram. It helps us that how we can divide any injury which comes to the hospital into pre-injury, then the injury event, and the post-injury. And whatever is in between can be measured and can be improved. And this is the way how we can do it through the trauma registry. So the purpose is pre-hospital care. So it's not only limited to the hospital. Okay, we need to look pre-hospital care provided by the 1122, our AD ambulances, all the NGOs and the private ambulances. Then we need to look into the rapid transfer to the best local facilities. Now imagine if the patient who was involved in a massive road traffic crash in middle of Sharai Faisal and been taken to the local private hospital, where there is no such facilities to look after the patient. So we need to identify this. There needs to be a system to transfer the patient from pre-hospital care to the definitive hospital care system. ATLS principle, ATLS has been discussed by Dr. Madeeha and other colleagues as well. We need to adopt the principles everywhere. It should be standardized. Then we've got integrated trauma services, and this is what trauma services needs to be in the country. And the trauma center SMBBIT is working very, very closely with the government to improve and make an integrated trauma system in Sindh. And as a result, we've got our own first Larkana Emergency Response Center, which is functional for more than a year. And it helps us a lot because the patient used to come directly from Larkana to us without any pre-information and without a good management. But after establishment of this center, they do stabilize the patient in the response center, and then they coordinate from Larkana to Karachi before they send the patient across. So this is integrated trauma services. Then we have got to invest in rehabilitation services. This is lacking, as we all know. The patients who comes into the trauma center or in any hospital, they stuck. They will go to the OR, they will go to the wards, and once the injury has been dealt by the specialist, they don't want to deal with the patient and they want to discharge the patient, though they need a rehab. So the rehabilitation is the area where we need to work on. Then audit and research injury systems, very important that without auditing and researching the injury, the system of the care cannot be developed, and this is what all about trauma registry is. The effectiveness in any setting, the essential operation of an effective trauma registry requires a couple of things. So the recipe is you need to have a funding, adequate funding to run the trauma registry. And then you need to have a reasonable and dependable software. Without software, you cannot gather the data. Then you need to identify the population you are looking at, and then train personnel for the trauma registry. Not everyone can gather the data. You need to train them according to your needs. Without training, the trauma registry cannot work. And then data collection. There needs to be a process for the data collection, reporting and validation, and then privacy. It's very important that your data remains in the good hands. Nobody can access. So privacy is very important. Move on to the variables. There are different variables in addition to the demographic details. Most registries includes. Now, it depends that what exactly you're looking for. So what we look in the trauma center, we look into the injury mechanism, we look into the scoring systems, we look into the radiology, the treatment and the procedures being done, the laboratories being involved, and the patient's outcome, which is very, very important. And the vital signs that on arrival and consecutively what the vital signs been, the utilization of the hospital resources. And then another important thing is that you need to understand that inclusion and exclusion is very important. Otherwise, you won't be able to measure it. So you need to decide that what you need to include on the trauma registry. This has been revised continuously in trauma center, and this is the third time we have revised this year, last month, that what we should include and how we will include, because I'll take you the history in the next few slides that what exactly we come across. So it's very, very important that the duration of the time since the injury, that what duration you want to include as an inclusion, maybe 24 hours old injury you want to include, or more than 24 hours, you need to decide. The admission length, in few hospitals only 24 hours is counted as significant time, and others will take it up to 36 or 72 hours. And the injuries involved as per system, so you need to identify what do you classify as a major trauma or the injuries you want to measure or you want to look into to improve the outcome of the patient. And then obviously you need to have an exclusion criteria accordingly. So let's look at the challenges of the trauma registry. Broadly speaking, we will all come across with this, the stakeholder engagement, funding involved, staffing, missing data, data dissemination, and some external factors. We will look into each with some challenges and the recommendation that what we come up with these. So stakeholder engagements, the barriers are the low admin and clinician buy-in, academic only. So the perception is people think that it's just extra workload on me and it has nothing to do with the patient's care. So we need to stop this and we need to teach the people that there is a need for the trauma registry to improve the outcome of the patient. So it's directly related to the patients. So one more thing, registry champions. If you want to run the registry, you need to identify one person who will become a champion for the registry. And they will go and talk to different departments, maybe the head of the departments or the stakeholders, to let them know that what exactly it means. So creating a champions in the trauma registry is a good idea. The next is the funding. Funding is always a big issue for all of us. So no long-term plans being looked into. The resources are very, very limited. So what we can do, apply for the grants in different areas from different resources, and try to use the free software and get the help from the health department. When I use the free software, there are softwares for the trauma registry. Recently, we have collaborated with the WHO. So the WHO is running their own trauma registry. So we have collaborated. So that was the way, so we can use their free tool and to improve our learning as well and the outcome of the patient. Staffing is another barrier, high turnover, no dedicated staff, so you need to hire a dedicated staff who work only for your trauma registry. What you can do, you can utilize your students, you can assign the nurses on the job, okay? That will help. Infrastructure has got limitations like a hardware, the internet facilities are limited in our country. So there is a solution that use offline data entry system, utilize the paper backup and the use the shared spaces if there is no office available for the registry. So the solutions are there, we just need to look at it. So data quality and the use, the barriers are incomplete charts. Most of the times we come across the files are gathered and the data is missing. If the data is missing, we cannot put the entries into the trauma registry. So we need to fix that by simple forms, make the forms very simplified, don't make them complicated, minimum data sets, promote data use in the policy. So in short, utilize the forms which being used in the emergency department or in the ward, which can be easily utilized by the trauma registry staff. Dissemination of the data, there are barriers that limited use of the data for hospital guidelines. So suppose you have come up with something that, okay, we have seen one issue consecutively and the improvement required. You need to set up a guideline, okay? If you don't set up a guidelines and you don't share anything with the government for the pre-hospital level or even for the hospital you require some help, you need to talk to the stakeholders. And then what you need to do about it, you need to involve the admin and clinician together to develop the guidelines and report it back to the government. Then next is Pakistan Trauma Registry. This is the name we come up with to give it in 2023. We established our own SMBBIT's Pak Trauma Registry. Initially, if we go back in 2017 or 18, we bought a US-based trauma registry, which was very expensive for us, but that was just a beginning. We were learning that how to do the, gather the data of the trauma registry, so we learned a lot, but then we realized that it's not working for us paying that much amount, and it was quite difficult to understand because it was totally adopted for the US. So adopting in the Pakistan, it was nearly impossible. So we come up with this idea that we should develop our own, which was done in 2022, locally developed by our IT guys, and we launched it in 2023. And it really helped us now because everything is in-house, we can do whatever we like, we can change the variables, and we can do the data input and output, whatever we need. We don't need to pay any other third party to get the data. So plan is to implement. So the next plan for this trauma registry, as it's been done in Karachi, the plan is to disseminate all across the Sindh. So Larkana Center is the first one, then we're developing the Larkana Center very soon, and then there are 3 more projects in the Karachi which will be started soon as under the umbrella of SMBBIT. So we're planning, and then all the other public sector hospital, if they want to adopt, we will speak to the government that it should be adopted. This is what our trauma registry, the login page looks like. It's dedicated. And this is the variables which can be utilized. So the data we have very comprehensive. It depends what exactly you need. You don't need everything to start with. We have come up with this in 3 years or 4 years times of the work. We have progressed. I will share some statistics for last 2023 and 2024 year, that what exactly comes out if you have a trauma registry. It's a very simple snapshot of the data, what we have done. So 3,416 patients we recruited. And as you can see, the gender distribution, it's a disease. Trauma is a disease of a young adults. And you can see that it's more in the male as compared to the female, so 70-30 ratio. And then you can see that what is the mechanism of the injury. RTA is on the top, more than 60%, then the falls and then assault and then few others. Then among RTA, you've got a motorcycle accidents. So it gives you some idea that RTA is happening the most. Which kind of RTA, what vehicles are involved? Motorcyclist, okay? If you look into further details, you can come up with the data that most motorcyclists sustain the traumatic brain injury. And then you look further that why traumatic brain injury? Lack of helmet use. So you can utilize this information to set up the guidelines for the pre-hospital systems and then send it to the government that this is what we understand with the data, because government don't have a data. Clinicians can provide them. So it helps. The next is a take home that what exactly the trauma registry is not just about data. It's about improving care. It's a system. Without action, data collection is meaningless. So we collect, but we need to utilize it. Champion leadership, as I mentioned, simplify the processes and integrate with the policy is the key. And thank you very much.
Thank you, Dr. Azer. Our next presentation is by Dr. Asad Irfanullah, consultant interventional radiologist at Hennepin County Medical Center, Minneapolis, Minnesota, USA. This is a pre-recorded discussion, and the topic is role of interventional radiology in abdominal trauma.
Assalamu alaikum. I hope everybody is well. Thank you for the invitation. I am not a big fan of online presentations. It's hard to gauge the audience, but under the circumstances, glad to contribute to this meeting. Brief background, I am an interventional radiologist. I graduated from Aachen University many years ago and currently work as an interventional radiologist at a level 1 trauma center for the last 20 years. So my topic today is role of interventional radiology in abdominal trauma. Presentation goal depends on the target audience here. I think most of the people in our audience today are surgeons in training and surgeons as well. So I will keep it focused with the surgical audience in mind. What has changed now over the years is the rapid availability of CT scanners now versus like 25, 30 years ago. And this is what has revolutionized interventional radiology intervention and also trauma workup. Now a CT scan is now basically an integral part of any trauma workup, and it helps determine whether and when we engage an interventional radiology team, and it also kind of understands when to engage IR. The key question arises when to perform a CT scan, and this is a conversation that obviously is made by the emergency medicine doctor and the trauma doctor who are on hand. Our general recommendations are obviously anybody with severe injuries who is hemodynamically stable and can make it to the scanner. Scanners are obviously now multi-detector, and scans can be done within a minute. And these scanners should be located within the emergency department. Another indication is when the physical exam is not really answering your question. And basically anybody with altered mental status and you want to see what's going on, anybody with pelvic fractures that's stable, all these patients should be getting CT scanners. Unfortunately, in Western medicine, we tend to image way more than we should. And basically, we joke that patients pass through the CT scanner even before they see a human being or before they are even seen by a physician. Not ideal, but that's the way Western medicine that's the direction Western medicine is heading. Like to talk a little bit about scan protocol. So as trauma surgeons, all of you should be able to look at the scan and understand the scan and also make interpretations and discuss them with the radiologist. All these scans, obviously, oral contrast no longer needed for trauma scans. Intravenous contrast is an absolute must. I want to take some time talking about the bolus timing. So at our institution, we do what's called a dual phase imaging or a double bolus. So we inject 30 seconds and 70 seconds prior to performing the scan. So this allows us to do a single scan. At the 70-second delay, we are picking up the parenchymal organ injuries. And at the 30-second delay, we are picking up maximum arterial opacification. Some places will do 2 scans. They'll do an arterial scan at 30 seconds and do a second scan. At 70 seconds, we combine both and we do a double bolus technique. This is something you guys need to talk with your radiologist and understand how these are done. So critical to know how the scan is done and to be able to read them. Basically, we have a resident usually on our scanner that's engaged with the trauma team. And if the resident calls or sees active extravasation, which basically means that there is contrast outside the confines of a blood vessel, they will call us, regardless of the time of day or night. So often we get 3 a.m., 4 a.m. calls that we see active extravasation. So this is the key buzzword, that we see active extravasation. Regardless of the patient's stability or instability, we are engaged and we look at the images. And then the next step is the conversation that we as our interventional radiologist have with the trauma team, which is obviously the emergency medicine doctor and the trauma surgeon. And our goal is basically to first kind of diagnose and see where the bleeding is and give our input as to if we'll be able to intervene to help stop the bleeding. I'm just going to illustrate a quick case in point. And this is obviously, we see this like multiple times a month, so young male with a fall, fast exam is positive, his blood pressure, he's stable, blood pressure isn't too bad, but a little tachycardic. So what do you do next? At our institution, this person will get a CT scan. Since he's stable, the fast exam is positive. And this is the CT scan. I will kind of pause through it here. You can see off the bat, there is splenic injury, grade 5 splenic injury with active extravasation. No other evidence of injury. The kidneys look all right. Vascular structures look okay. There's blood in the pelvis. So based on imaging and clinical parameters, we were activated. We looked at the scan. I looked at the scan. If this were an active talk with a live audience, I would actually pull the audience and say, what would you guys do next, right, at your institution? Here are our options. Would you go to surgery, do a splenectomy? Would you kind of do watchful waiting since the patient's stable and see how the patient declares, or would you send the patient straight to IR for catheter angiography? Obviously, the answer, you all know the answer. The splenic angiography is probably the most frequent trauma procedure that I perform, and it is critical for the IR provider to look at the images, grade the injury, and come up with a management plan. Grade 4 and grade 5 injuries are what we typically come in for. So when it's within the confines of the spleen and there's active bleeding, it's 4. Once it exits the confines of the spleen, hemoperitoneum, it's a grade 5. Have your radiologist put the grade in their radiology report as well. So grade 5 injury here, other cases, I'm just going to move quickly in the interest of time. So we decided to do an angio. These young patients, you can come in and out really fast and do angiography really quick. There's no concern for arterial disease, for PAD. Typically, right groin, select the celiac axis, do a non-selective celiac angiogram, and then go selective into the splenic artery. Here you can see there's active bleeding from the upper pole. About 10, 15 years ago, I would try to be sub-selective and go in and coil the area of active bleeding, which I actually still did in this case. We put these microcoils that are little fibered coils that basically act as plugs that stop the blood flow. I have now started, and this is kind of standard of practice, to do proximal splenic artery embolization. And this literally you go in and you can be done in 10 minutes. And the concept of proximal splenic artery embolization is to preserve the flow to the spleen. This is a scan a month later, so you kind of preserve the collateral flow, and the spleen still perfuses. So the anatomic concept here is you go between the dorsal pancreatic and pancreatic magna arteries, so you're preserving flow to the pancreas, and also through collateral flow, you are preserving flow to the spleen. So basically what's happening is you are preserving flow to the spleen and also reducing the pressure head to the spleen. all in procedures have complications. As surgeons and radiologists, interventional radiologists, we deal with these complications. There's a 21% incidence of splenic infarct, 5% requires splenectomy later on, about 3% gets splenic abscesses. We currently have a patient that did develop a splenic abscess that we are treating with basically catheter-directed management. So something to be aware of. Quick pearls indicated for grade 4 and grade 5 injury. If the patient is unstable, and you want to act fast to proximal embolization, if they're really unstable, go straight to the OR. But if you can wait for the IR team to come, that's better. Here's another case, I guess, of proximal embolization in which we maybe went a little too distal and we got complete splenic infarct. So complications do happen, just pointing out, that sometimes interventional radiologists can have complications. It doesn't happen very often, though. In a resource-poor setting like Pakistan, I worked in Pakistan for a few years at Indus. I still come to Indus Hospital, and I worked at Dow Oja campus. And if you don't have coils and you want to get control, you can also inject gel foam slurry into the splenic artery just to slow the pressure head. The issue there, obviously, with gel foam, not ideal, but there's increase in risk of infection and splenic abscess formation. The other organ that is commonly injured is the spleen. This is the case with splenic and liver injury, active splenic and arterial bleeding from the liver and the spleen. Again, celiac angiogram, you can see the active bleed from the liver, treated with coils, and then these coils unfortunately migrated a little distal, but there was no repercussions. Can't do proximal embolization in the liver. If the patient is unstable with multiple foci bleeding from the hepatic artery, you can do gel foam, which is kind of a temporizing solution. Often patients with massive liver injury will go straight to the operating room where the surgeon will pack. And if they can't exactly identify the injury, they'll come to IR post-OR. Liver complications post-embolization, obviously biliary strictures, abscess, liver infarcts, similar to the spleen. Biliary strictures, obviously specific to liver injury. Kidney is the least frequently injured organ. In this case, patient had penetrating trauma with a pseudoaneurysm or aneurysm of the renal artery with retroperitoneal hematoma. In this case, we did coils and then we covered the pseudoaneurysm with a covered stent graft. So, elegantly treated, avoid a nephrectomy. And this is a scan actually a year later that shows good perfusion of the kidney with maybe a small cortical defect. So great way for nephron sparing. Penetrating polytrauma, this is a massive injury, patient's unstable. If they can come to the IR suite, then basically there's an injury of the renal artery treated with a stent graft. Again, you really need these on your shelf to be able to, provide effective IR services. Pelvic injury and pelvic trauma is probably the most rewarding procedure that I do, is just because the impact is so immediate. Anybody with a pelvic fracture that's unstable, these patients can actually skip the CT scanner and come straight to IR. It's easy enough to inject the internal iliacs and look for active bleeding. So your protocol is the patient has a pelvic fracture and they're somewhat stable. You can go to the CT scanner to see, where the fracture is and which is it coming from the right or left side. If they're unstable, and especially in geriatric patients, they come straight to IR. These are hard for surgeons to treat. And then basically, this is a 2-for-1 case, motor vehicle accident with a thoracic aortic injury and a large pelvic hematoma, elegantly treated percutaneously with the aortic stent graft and coil embolization of the internal iliac artery injury. More indications of pelvic injury with irregularity of the iliac arteries. This is the orthopedic misadventure. The orthopedic stabilization screw went to interior, damaging the internal iliac. Patient had significant bleeding on the field, and we went in and just coiled the internal iliac artery proximally with great angiographic results, and the patient stabilized as well. Bowel injury is the nemesis of all surgeons. These are hard to detect on CT scanners, and you need a sharp radiologist to be able to identify bowel injury on a CT scan. These are subtle. Sometimes all you see is a small amount of free air or free fluid or devascularization of the bowel loops. Bowel injuries need surgical intervention, limited role of IR in small bowel injury. This is a patient, with a left diaphragm injury, and you can see active extravasation within the mesenteric root. Obviously, since the term active extravasation was used, IR was reached out to. But this patient really needs to go to the OR for exploration and fixation of his bowel injury and diaphragm repair. So no role of IR here. Other than blunt trauma, penetrating trauma, obviously gunshot wounds and stab wounds. bowel injury is more common. In the interest of time, let's just skip to the next case. So a stab wound with a large area of active extravasation from the liver. This patient was stable enough to come to IR, and you can see, there's an area of active bleeding, a large area of active bleeding, effectively treated with coils. This was quite a dramatic case that we did recently. Patient with, again, another orthopedic misadventure. Their posterior stabilization screws went too deep with severe injury to the abdominal aorta. This patient actually coded on the OR. So our IR suite is right next to the OR. His hemoglobin was 4. They were actively resuscitating. He came to IR, and this is the image, just in active extravasation, just blood pouring out from his aorta. Again, percutaneously treated with the aortic stent graft. Just a one stent, and the patient stabilized. So this was truly a life-saving procedure for the patient. So the problem obviously is in Pakistan, you need these stents on your shelf and the tools available to be able to do this at a moment's notice. In summary, for the surgeons, it's a collaborative team effort. You need top-level, surgeons, trauma surgeons that are comfortable going into the OR right away in collaboration with an IR team. And everything is, understanding communication is key. In Pakistan, resources are the challenge. So the recommendation here is the IR team is basically the physician, a nurse, and a technologist that's on call. Our response time is 30 minutes, so we obviously are at home when this happens. So we get called in, we come in, and we activate our trauma team. The anesthesiologist takes the patient into our IR suite. If we can get an early CT scan, look at the images, we have a better plan of how we're going to approach the patient. And it's basically communication. Often, on occasion, I've been called in, but on my way in, the patient became too unstable, and they ended up going to the OR instead of IR. But we are committed, and we come in. So the other biggest challenge in Pakistan is the availability of material. So at a minimum, make sure that if you want to develop an IR call team, make sure you have coils and gel foam and stent grafts. Thank you very much. This is my email. I'm happy to answer questions via email.
All right, so our last presentation from today is by Dr. Fahad Umar, Associate Professor at Khan University Hospital and a leading voice in the integration of artificial intelligence in oral health care. He combines clinical expertise with cutting-edge research to develop AI-powered solutions aimed at improving diagnostic accuracy and access to care, especially in underserved regions. And his topic of discussion is based on artificial intelligence. Please welcome Dr. Fahad Umar.
Thank you very much. I'd like to take this opportunity to thank Dr. Hasnan Zafar as well as Madeeha for inviting me, and of course the society for inviting me to this meeting. So let's get to the presentation itself, and maybe you're wondering what a dentist is doing in a surgical conference, and please know that the feeling is similar for my side too. I feel like a fish out of water, but we'll try to make this interaction a little bit more meaningful for you. So this is my disclosure slide. Most of the work that I've been doing is being funded by different kind of intramural as well as extramural fundings. These are my professional affiliations, and of course my major professional affiliation is that I'm a clinician at the Khan University Hospital, and some of my work revolves around academia and research. That's 20% of my work, and this has given me an opportunity to work with different kinds of professional organizations. So November 2022 marked a watershed moment in the history of mankind. This is when ChatGPT was first released, and the true potential of AI was actually realized by the general population. And this was being heralded as the fifth industrial revolution that's coming our way. This is largely because the economists think that this is a disruptive technology, and disruptive technologies are any technologies that change how people work and businesses operate and people think, and that's exactly what ChatGPT did. And according to certain economists, the role of AI is going to add $5 trillion into the global economy. This is just based out of increased productivity that's going to come out of the use of artificial intelligence. And therefore, for us as surgeons as well as healthcare providers, this is an opportunity to take notice and also take heed. When we talk about AI, there are different kinds of definitions that come forward about deep learning, etc. But from a productive standpoint, I like to classify AI into two distinct forms. One is discriminative AI and the other one is generative AI. And discriminative AI is basically any kind of AI that looks at pattern in terms of data, and then based out of those data patterns, it decides whether what it is looking at is either disease or non-disease things. Likewise, in terms of generative AI, it also looks at data, but actually learns patterns in those particular data and then generates new data points. So this is how ChatGPT actually works. It looked at a lot of plethora of text in the internet and then figured out what the semantic concentration of word or their meanings are like to one another, and then it generates new text. And likewise, this can be utilized in terms of drug discovery as well as generation of images, radiographs, synthetic data sets, etc. This gentleman is Paul McCarthy, and he's the gentleman who actually termed the coin AI back in 1956. So artificial intelligence is not a new thought process or terminology. Over the course of its history, artificial intelligence has seen ups and downs. So there's been renewed enthusiasm and lack of enthusiasm in terms of AI research, and this has gone through its ebbs and flows, and these are known as the AI winters when the research was not being done during the time of AI. But something changed in the early 2000s, and this is because the internet came in, and when there was internet, we got resources such as cloud computing coming our way, so people could host a large amount of multifarious data, such as Microsoft Coco or ImageNet. Likewise, we also had accesses to a specialized kind of compute, which is known as a GPU. And we also had access to certain kind of artificial intelligence packages, which could simplify the learning process or the AI training processes. So now in 2007, as we all know, that AI works with a lot of data, and we need a lot of compute to utilize it. So the actual true power of AI started realizing actually in 2007. And there was a lot of research being done, especially in imaging, even before ChatGPT came in. And this was the time, actually, when we were also working on AI. So we started working on AI 2 years before ChatGPT actually came in, and AI was fashionable. And with that background, I'd like to talk a little bit more about my research philosophy. In 2015, WHO came up with a concept which was very simple, which is known as the Sustainable Development Goals. They said that as a global community, if we work towards these 17 goals, we can progress in, all countries can progress together in their development phase. And these sustainable development goals have been a center of attention by not only Pakistan, but our university as well. And naturally, us being healthcare providers as well as educators, we gravitate towards the two most important sustainable development goals that are most relevant to us. However, we also note that our progress towards these sustainable development goals has been rather slow because of the challenges that our preceding speakers have already spoken about. We have economic challenges, we have different kind of cultural challenges. So this AI provides us with an opportunity to leapfrog ourselves, and we can somehow utilize the AI to improve access to healthcare for our patients, as well as utilize AI to deliver personalized learning for our residents as well as students. With that background, I would like to show you a couple of things that we're doing. We're not just doing AI-based research, we are actually doing deployments of computer vision models as well as language models in real-world scenarios. So this is Mithi. Mithi is a region in Thur Parker, is actually a city in Thur Parker, and this is government boys high school in Mithi. Something unique about this government boys high school is that this is a place of one of the biggest deployment of an AI-based oral healthcare solution in our part of the world. So what we're doing is we are taking pictures, and based out of those pictures, we are making diagnosis of decay or not decay. This lets us know the disease prevalence of decay in the community. The learnings from this project made us realize that we can also utilize it for early detection of cancer, etc. And how does that translate into surgery? Well, for surgeons, we also treat, especially for trauma cases, we treat different kinds of injuries. And imagine if you develop an AI-based module which the patient can take home with them and look at their wounds, or with their smartphones, look at the wounds and see if there's any kind of a wound infection going on, so that you can get actionable insights as to how to deal with that, and the surgeon is also aware of if something is going on. Likewise, we've also been working with X-rays in our department, and what we try to do is automate one of the most important or most common X-ray that we do, which is in OPG. So we were able to do that. We not only identify 11 different kinds of diseases on that X-ray, but also give a diagnostic report. Likewise, these kinds of X-rays or imaging devices, or advanced imaging devices, can be utilized during the primary or the secondary screening of the ATLS, and may actually improve the outcomes of our patients, so that we can get those actionable insights and do that. Likewise, we've also been utilizing large language models. So this is a project that we did with something known as the multimodality. What happens is, whenever there's a dental injury that happens, people don't know how to treat that, right? And the patient usually present in the ER, or the first care provider is either a student or a teacher or first responder. So the treatment of dental injuries is somewhat nuanced, and different cases require a different kind of ways in which to treat them. So with utilizing a multimodal AI, what we do is we empower the provider. They can take pictures of that injury site, or write some kind of a history, or even speak that history, and then the AI will let you know what the best treatment modality is. Likewise, this kind of multimodality can also be utilized in the ER triaging area, so that treatment can be prioritized. We also looked at AI, and we wanted to know whether it can also tell you something about post-operative care. And we noticed that AI can actually provide really good post-operative instructions, so that you can concentrate on your patients rather than having to deal with them in terms of their post-operative care. And as a teacher, I've also utilized AI in teaching and learning. Benjamin Bloom is an important researcher in terms of teaching, and he spoke about the 2 sigma problem. What that essentially means is, if you provide one-on-one personalized tutoring to any kind of student, they will improve in terms of their output by 2 standard deviations. That means that an average student can become an above average student. So we wanted to test whether we can utilize AI, and would that increase the residents' learning. So in our journal clubs, what we did was we started giving our journal clubs 1 week in advance, and we trained the AI utilizing a specialized technique known as retrieval augmented generation. So that journal club, before the journal club, we provide the AI with specialized knowledge in terms of statistics that are going to be spoken about during that journal club session, as well as domain-specific knowledge. And we found out that the engagement of their residents actually improved during the journal club sessions. And we were able to publish that recently last week. And these are a few examples of how we can utilize AI, and we barely scratched the surface of how AI can actually help us. In the future, next year or in the coming years, we're looking to working with fellow colleagues in other domains, so that we can utilize AI for the betterment of our population as well as our children. So with this explosion of AI and different kinds of models that have come up, we always get this existential problem coming in meetings, and everybody comes and speaks to me and says, is AI going to replace us? I always say that AI is not going to replace us. We just need to develop the skills of the future which are required. This is something that we need to embrace today. So as academician, we need to understand that the pedagogy of teaching and learning is going to change. We don't want our students to be generators anymore. We want them to be better editors. We want them to understand what they're reading and then utilize that AI and make actionable understanding or something from that AI, rather than just saying don't use AI and just write something for us. Likewise, there are new opportunities in research that is coming up. So we don't know what the ethics of AI would be looking like. Likewise, we need people who will be doing validation studies in terms of different kinds of their domain specificity in AI. We want data scientists coming in who would standardize and curate that perfect data set that we need to train our AI for. And if you're a clinician, we need you to check and assess the AI in deployment. We want to make sure that we are aware of the AI biases and we are aware of how AI can actually help us, but at the same time, what are the shortcomings of AI? So certainly there are a lot of ways in which we can contribute in terms of research as well as benefit from the AI. Another important point that I always like to make is whenever I talk about AI, people come up to me and say, the AI is being developed in the high-income countries. Why do we need AI in our part of the world? Well, as the speakers before me already spoken of, our resources are different, our disease prevalence is different, our patient demographics is different, our injury presentations are different. And based on that, if we try and utilize an AI that was developed in another part of the world, it will not work so well in our part of the world. And therefore, it is upon us to develop the AI which is context specific to our population. Here's an artificial intelligence pipeline, and this is the area where we can contribute, because as domain experts, we have access to the data sets, and we are the ones who would be annotating those data sets. And we need to develop a synergy with colleagues who are computer engineers, who would be able to deploy the solutions that we've generated. And therefore, I proposed, in order for us to move forward in terms of AI and the adoption of AI, we need to develop center of excellences. As academicians, as well as researchers, we need to, and of course providers, we need to focus on these two sustainable development goals, and we need to all come together. This center of excellence does not have to be a brick and mortar anymore. With the advent of cloud computing, we don't invest on making buildings, we invest on making collaborations and bonds. And if you want to get into the AI research journey, you want to start off with something easy. So this is my advice. Usually these are the platforms which are free that you can utilize, not only to learn, but also test out different kind of AI platforms that are available to us. We also do certain courses for healthcare providers. These are general courses that we do, in which we teach the fundamental of AI, so that if anybody wants to do or understand AI-based research, we can help them out. With that said, I would also like to thank my team who developed these algorithms with me and also deploy them and test them. Thank you very much for your time. And maybe in the end, we can answer some questions.
All right, thank you, Dr. Fahad, and that was a very interesting take on artificial intelligence. So the next segment is Q&As. We'll begin with our chair and co-chair. Any comments, Dr. Hasnan Zafar and Dr. Zubair?
I think we'll start with the question and answers. If we have any questions, you may identify yourself and ask from whom would you like to ask the question. If anybody in the audience would like to ask.
So I can begin first, actually. So I would like to ask our anesthesiologist, actually. So you've been talking about this massive blood transfusion protocol, which is basically 1:1 transfusion that we give to the patients. I would like to ask that in the practicality of our work, we see that there is no availability of blood in such volume. And it's even in the best of the centers in Karachi, we see that the blood is not available with this concentration or with this type. We don't have this 1:1 ratio all the time available. So what are your takes on that, Dr. Faisal or Dr. Nasir?
Thank you, Sohaib. So, I mean, this is the area where we need to develop our blood ordering schedules and So keeping the blood, some kind of registries or some kind of trauma banks on a national level or on a city level where you can have these kind of availability at times, because this is a problem. You have to make some drives to have the availability. Again, the problem is if you want to use component therapy, then it needs to be 1:1:1. I mean, crystalloids, we know that from the literature, if we give a lot of crystalloids, it do harm. So earlier, the blood banks should have some kind of reserve blood for these kind of high volume trauma cases. I mean, the centers can be identified where high volume trauma cases occur. So a blood kind of reserve blood should be there for massive transfusion protocols.
Thank you.
Yes, I agree to Dr. Faisal Shamim. Other thing is that as we have a trauma registry, so we can do a public awareness blood donation program as well. So we have to do such programs as much as possible. Then our blood bank should have more blood for these trauma patients.
So collaboration is important in this scenario.
I want to add something. I'll add my personal experience with the trauma center. I would recommend that you should talk to your blood bank, right? Because I was surprised when I struggling with the same issue. When I had a meeting with the blood bank, then we realized they do have O negative blood, which we don't even ask. So if you communicate very well and you discuss that what are your requirements, you will be surprised the results.
All right. So any more questions from the audience?
Hello, Assalamu Alaikum. So my name is Simra Iqbal. I'm a final year medical student at Dow Medical College, Karachi. My question is from Dr. Azer Shaikh. So I recently performed a retrospective cohort study from the vascular and endovascular surgery department, SMBBIT, and the data through the IRB platforms. But one thing that I've noticed is that the data is very hard to extract in a way that you need to go through multiple, I would say, अलग-अलग institutions जाकर आपको फिर access मिलती है उनकी. And one thing that I've noticed in a public sector, such as in Pakistan, what we can do is make the data more publicly accessible, like the CDC or NHS public data, like they publicize their data. So what do you think? Is it something that can be implemented in the future, or is it something that's already under the way? Thank you.
Just to add on to her question as well, I also had a very similar question. It was about, for instance, we have access to the CDC Wonder like data sets and other national inpatient sample data sets, which are usually predominantly based in the US. So when it comes to trauma registries, do we have access to those kind of data sets that we can eventually implement into research, or do population studies that help us improve our systems overall? Thank you.
Right. You've got two questions basically. The first question is that you struggle to gather the data as been working through different institute for SMBBIT. So we all safeguard the patient's data. That's what our aim and the goal is, because in most of the public hospitals, you would realize any data can be taken to any place, which is not appropriate. So you remember in my talk, I did discuss about the privacy of the patient's data. So that is the reason, and I'm very glad that this is the information you provided. It means it's working. So there should be some hindrances, though you have to follow the some rules, regulations, the protocols to get access to the data. And thanks for that. The second question is whether the data can be publicized. So we're not that much advanced at the moment. Initially, we just gathering the data, we're learning how to gather the data. And the next step would be how we can share and how much we should be sharing with the public. I know confidential data to keep the patient privacy. Hope that answered the question. Thank you.
Please, Dr. Sen.
Communication and collaboration, which is fantastic because trauma is a team sport and multiple teams come together to play. We had something looking into future with Dr. Fahad's presentation. So overall, the session was excellent. I have just one comment or a question to ask related to registry. One of the purposes of registry is to actually look at the outcome. So if you have a severe extradural hematoma in a 25-year-old, what is the outcome? This may not necessarily be public, but it may be delivered to surgical teams who are taking care of that patient. We have collected data on in our hospital on surgical outcomes. That's called NASCOP, it's an American registry, and we are providing this data to individual surgeons. We find it very difficult in our cultural context. So my question is, at your registry, do you have that data?
So, hello? Yes. So we do have, in initial phases, we do have a data for the general surgeons, we got neurosurgeons, orthopedic, but you're very right, the atmosphere currently does not allow you, but we are building that relations with all the specialties to share that what exactly the problem is. So we are in infancy, right? So it's just started. So we have to go a long way, but yes, and just to help this registry in the background, we implemented the M&M meetings, which was not existing in the trauma center, and that has helped to bridge that gap. So through the trauma registry, not directly, but through MMN meetings, we initiated that to sharing the concerns, what we are coming across in the registry. Thank you.
Assalamu alaikum. My name is Yumna and I'm a medical student from Dow Medical College. I basically had a question for Dr. Azer. He basically gave an excellent talk on how to build a trauma registry, right, which he did for like the Sindh province he's implementing to do. I basically wanted to ask is like if there's a plan to build a centralized one for Pakistan, and if we are making like individualized for various like hospitals, can they be based on a specific model ताकि फिर data analysis करने में we have ease and they can be amalgamated together?
First of all, thank you that you enjoy my talk. Secondly, your question, I think I did mention in my presentation that the idea is to implement the trauma registry not only in Sindh or across Pakistan ultimately. That's why the name we chose to give to trauma registry is Pakistan Trauma Registry. So there is a model which is, I have shared our software which is locally built for the trauma registry. The variables may well be a little bit different. Say for example in Larkana Center, they don't have all the variables which we can use there because of one or the other reason. So initially the software is same, the training is same, but maybe the variables a little bit different as compared to the Karachi. And the idea is once it's been implemented and we know that we are progressing, then it will go further in Karachi, maybe other public sector hospitals, and then private hospital if they want to adopt. So it will become a centralized backbone for Pakistan registry for the trauma.
Thank you so much for your answer.
So any more questions from the audience? Right here.
Assalamu alaikum. So I have a question from Dr. Zubair. Sir, ATLS training has been here in Pakistan since long. So do you think there is a change? Because the main concept of ATLS is team. So do you think that in our hospitals now we have well-organized teams for the trauma management, or still it is discorded? Means once there is trauma patient, we are, for example, if it is head injury, we are calling the neurosurgeon. If there is abdominal trauma, we are calling the general surgeon. Is it still the same, or is there any change?
Right. So ATLS is started somewhere back in 2007 in Pakistan. And so it's almost now 18 years. The training has been there, but the number of trained people is still not what it should have been. And because of limitation of faculty and a lot of resources. The second important thing is the mindset at the local facility where trauma is being dealt with. So the places where the local faculty and the local administration is interested, probably you see some development of team. Whereas the places where you do not have that facility, so among 20 people, one single trained people is most of the time drained out and is not able to do. So if you ask me what has happened, I say that the desired outcomes have not been achieved. So there are a few things which people are thinking about to bring some change. Let's see what happens. But the desired outcomes that we should have gained till now are not there. Okay, so if there are no more...
My name is Dr. Zayed Ali Memon, and I'm asking from Dr. Faisal Anesthesia. There's always, he has presented a debatable talk, and most of the time, this is the main problem, that trauma is said to be a unique problem all over the world. But in Pakistan, unfortunately, we are not following that, what the world guidelines are there in all over the world. And he has already talked that this is a debatable talk, so always there's a debate. My concern is that is there any unique approach that we can approach how much fluid should be given in 3 hospitals like Civil, Jinnah, Aga Khan, and Indus, all the way? So why don't we develop a unique consensus or build a guideline so that everybody follow that? And it should be seen, and after that there's a registry forum so that we can see the outcome in trauma patients, because this is a forum where we can get together, and after that we can develop our consensus, because all the seniors are sitting over here. So I think this will build a more sensible concept if we can approach there. Thank you.
Thank you so much for your question. And I mean, you are very right that we should have our own guidelines and protocols to develop the fluid resuscitation. The problem, what happens is the nature of injuries and the type of injuries and the availability of resources. The guidelines, the Western guidelines, these are there. We are using those guidelines, and those all says that limiting crystalloids, yes. But sometimes what happens at the nature of injury is like that your blood bank exhausted and you just continue to give fluids and vasopressors. Now the understanding between the teams is that start fluid resuscitation, get the blood in terms of component therapy early, and then use the monitoring and especially the laboratory investigations, guided resuscitation. And then also what we need to look at our majority of the trauma types which comes to our hospitals. So definitely it will be a good collaborative effort to develop certain protocols and guidelines for fluid resuscitation. And definitely the society can come up with, to collaborate with the Pakistan Society of Anesthesiologists or the anesthesia teams across the hospitals. First, we need to look at the retrospectively the data. One of the most problem in our hospitals or in the public hospitals and the other hospitals of our country, that I'm very happy to see a trauma registry, but main problem is the development of registry is a very good initiative and it's doable. But maintaining the registry and getting the data, it's difficult in our country, because if you would like to do a collaborative study, people don't give your data and don't want to contribute. So yes, it can also be from the seniors, from the society platform, that something collaboration can happen. Thank you so much.
I want to add something. it's not just only the one guideline which needs to be unified for the IV fluids. There are several guidelines which needs to be centralized, unified, and I think all the societies, either it's a society of surgeons, anesthesiologists, or emergency medicine, they should come together and build a resuscitation society. That's the need of Pakistan, to look into all these matters which require in emergency department or in the initial phases of the trauma resuscitation or the medical resuscitation. Otherwise, if the surgical society will come up with something, maybe emergency medicine society will not listen to, and so on and so forth. And the second thing, as Dr. Faisal mentioned, that trauma registry, the constraints are to share the data. The good example I want to share that recently we had a MOU with the Aga Khan city department, and we are working very closely and we sharing the data with each other. And it's working very nice, and we learning from each other experience of the trauma registry. So it's a doable thing. You just need to communicate with each other and have that motivation. Thank you.
Right. So if there are no more questions, probably we'll end the session over here.
All right. So in the end, I would like to invite Dr. Syed Azari Raza to be on stage and give mementos to our esteemed chair and co-chair. So first, our chair, Dr. Asnan Zafar. Next for Dr. Zubair. So Dr. Hussain, Dr. Zubair, please stay on stage. And I would like to invite all the speakers to be on the stage to get their shields. So Dr. Madeeha Ali first. Dr. Faisal. Dr. Tariq, can you please join us on stage? Yes. Dr. Nasir, next. Dr. Azer. And now Dr. Fahad.
And finally now Dr. Sohaib.
Thank you all for joining us today. This concludes this trauma session. One announcement for tomorrow. There is breakfast from 8:30 to 9 a.m. sharp. So please be there for the breakfast. Thank you.
Thank you, Dr. Sohaib. This concludes our scientific session for day 1 of Surgicon 2025. Thank you all for your valuable participation and insightful contribution throughout the day. We look forward to welcoming you all back tomorrow for another engaging lineup of sessions. Have a pleasant evening. Thank you.